I placed a couple of waveforms today, thinking about volume control, continuous mandatory ventilation with set point targeting. And today, I think the message is look at the pressure. And there are several examples for us to go through. And they we start with some basic, and then we start going into a little bit more esoteric cases. So let's get started. So the disclosures, we discussed the particulars of ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic's opinion. You will see that I'm Eduardo Mireles and Rob Chatburn is on the line too. We both have some disclosures to make, which are noted here. The basic ground rules that we have is this is a recorded session, so keep your microphone muted. The moderator, that's me, may call upon you to comment according to what we find on the chat. The chat is the best way to interact with us, so use the chat just to as a function in WebEx. And at the end, Cleveland Clinic employees, if you can get a CME, if you just scan the QR code and you'll see the code at the end of the presentation. So please feel free to do so. So we're gonna get started, and this is the first waveform that we put on for all of you to read and go through. So you want to give it a try. So if you want to speak loudly so that they can hear you, and I'll be writing on the board as we're going through it.
Okay. So this should be VC-CMVs. I'm first looking at the flow variable. There is some PMOS there, but seems pretty controlled. So that's volume control. In terms of targeting scheme, I don't see color change, or I see that there is a little discrepancy there. So I think this Contour's calling it VC-CMVs. Load-wise, I'm going to go in the non-control variable. So I'm going to go to the pressure waveform, and I'm going to see, first of all, if I can try to get a breath without too much PMOS. I don't see a whole lot of PMOS in the non-control variable, so I don't think there is a whole lot of PMOS. There is a pretty high peak, so I would say that there is predominantly an elastic load, both inspiration and expiration. In terms of PV discordance trigger, looking on there seems to be delayed trigger in the first and the third wave. I don't see any. I'm thinking of delayed trigger because the flow waveform has flattened a little bit before it triggers. But I don't see a whole lot of patient effort here. How would some help?
Do you see any PMOS?
I see PMOS.
Where?
At the top of the plateau of the flow waveform, like in the flow waveform, there's
flow waveform?
Yeah, I mean.
So what are you controlling?
I am controlling flow. Yeah, I don't see any PMOS.
So this is important that you have to make an assessment and say, well, is there PMOS in this waveform or not? And what is taking you off logic is that you see these oscillations on top of the flow waveform, correct?
Yeah.
Yeah, so this should normally look like a square,
Right.
and instead of looking like a square, you see a peak and then this kind of oscillation.
Yeah.
But you don't see otherwise any evidence of PMOS throughout
No.
the waveform, right?
Yeah.
So whenever you see that, there's details with every single ventilator, and that's why it's important to start by the tag. And in this ventilator in particular, the tag for volume control, in this particular, it can be two types depending on what is activated. But in general, you see the waveform, and there's a very steep change in pressure, and in all of them is exactly the same or very similar. And you can see that the volume, it also stays the same height.
Yeah.
So unless there was some sort of reverse trigger that was occurring, or early trigger, as we call it, then that may explain that, right?
Mhm.
But otherwise, I don't see any activity before. I don't see any activity after in the flow waveform, and not clearly here. So I think that should raise your
There's no PMOS.
that there's no PMOS, or that there's something else. And now the question is, why is there all this irregularity occurring here, right? So why is there all this nonsense on top of this flow waveform? So do you see any trigger? So if anything, you could say, well, Eduardo, I'm not sure if there's PMOS, but if anything, it could be early trigger, right?
Right.
But after that, I don't see any clear PMOS anywhere, so I don't see any clear work shifting. I don't see, the cycle seems to be actually perfect. I mean, there's a pause that somebody put in. You can see it down here. The pause is set at 0.2 seconds, and the expiration, there's no activity, no patient effort at all. All right. So let's just go in order here and start by your taxonomy. So the first one is to see which one is the control variable, and this causes a little bit of annoyance on all of us. The first time we saw this is when we got this ventilator for the first time, and I saw this. I said, "There's PMA. I mean, why is the flow not a square waveform?" And it turns out that this ventilator, when the tube compensation is activated, it will change your flow waveform to look as if it was kind of a proximal or proximal waveform. It includes how it would look there based on the tube compliance and the change that is the circuit compliance, not the tube compliance, the circuit compliance. And this was something that we didn't know. It's not on the darn manual, to my knowledge, and it was disclosed to us by the engineers of the device. Okay, so in these circumstances, that would be the telltale sign is when you see this and you don't see any other activity of volume control that takes you there. And it's CMV because every breath is triggered by the machine, which immediately makes it mandatory. Okay. And set point because you set all the variables that you wanted to deliver, the tidal volume, the respiratory rate. You made a very good point regarding the load, and the load is elastic in this time. The first hike on pressure is relatively small, right? And then you can see actually if you put it in difference, this is the amount of resistive load, which and after that one, all of these from there to here is all the compliance, right? All the difference in pressure. So there's a small plateau here, but it's probably not long enough to allow it to go all the way back to the real plateau or that you want to measure. And so this is all really steep rise with a square waveform, which tells you that this is an elastic load. And so I agree with you completely. And so in terms of PV discordance, I don't really see any patient activity. But if you had a question, if there's activity, what would you do? Is there any ways to check if there's patient activity?
And turn the thing off.
What up?
That flow compensation.
You could do that. You could turn it off. Is there another one?
Expiratory occlusion.
Yes, you could do an expiratory pause. So an expiratory occlusion And you just leave it there and it goes for a while, and then you'll see if the patient is actually doing an effort. Now, if this was reverse triggering, you may not see it, right? Because if there's if it's a true reverse activity, yeah, so you may not see that. Rob, any comments?
Yeah, Ariel wants to know, can we say that it's not actually IMV type 4? And as you said, it could be that, or it could be just regular old set point, like you say. We can't tell by looking at it because there are no patient-triggered efforts.
Exactly.
And, there's no way to tell from just by looking at it.
Yeah, and that's a common thing because there is no marker. It would be nice if it would say volume control and a little icon or something that would tell you that it has the flow adaptation has been activated, so that then you would know one, that it's active, and number two, that what is the tag. But just by looking at the waveform here, it's impossible to see it.
So what question is that if we turned off the flow adaptation, then the flow would have become like perfectly geometric controlled.
No, flow adaptation is that little button that when we say that it's that function, that's the name of the function, that you have seen the button inside that looks like this, and it has this little tiki tiki tiki.
So what I mean, if we turn off that side,
That's circuit competent.
circuit comment. If we turn that off, then the flow would have been completely
It will be a square.
square.
Yep.
And then how do you explain a little plateau on top of the flow of the pressure waveform?
This thing here.
Yeah.
Well, there's a pause.
Okay.
There's an expiratory pause, right? So you do the expiratory pause, and it's a very
0.2
short.
seconds.
0.2 seconds. So that's
Got it. Yeah.
got it.
Mhm.
Excellent. Good questions. Unnamed fellow. Very good. All righty. Any other comments that came up on the?
No, but since we're focusing on the pressure waveform, to my eye, it looks like there might be a slight concave upward.
Yes, excellent. So very good.
Yeah, you're right. Hey, is the trigger early?
There's
No.
no patient effort.
Yeah, okay, I noticed it was underlined early. I wasn't sure. I wanted to make sure. Okay, thank you.
Yeah, no, that's an artifact or I'm gonna call it simulation that the ventilator does when the circuit compensation is on, trying to display what the circuit is actually seeing, in terms of flow. But Rob does bring a very good point. So you see how the waveform actually has these little changes in the it's not a straight slope. There is this pretty acute, and then it changes, and you can see it probably here again, right there, an acute change, and then this one it looks concave. It looks like that, and usually that's a marker of over distension, right? That's something that we would see under these circumstances. That may be of concern. So I put another image to help with this. This is the exact same human a little bit later. So I put this one also intentionally so that we can analyze this. But Rob brought a really good point here, in which, and this is a common thing that people stand by the side of the waveform and they look at it and they say, you know, this looks like it's over distension, right? That would be the immediate read on this. But remember that there's the flow. So let's take a look at the same patient. You can see now that I mean the FiO2 went a little bit up, the PEEP went down. It's 280 of tidal volume. The respiratory rate went a little bit down. There were some changes, and now you can see these readings. So let's start with the tag. It's exactly the same. There's no real difference, right? You agree with?
Yeah.
We all agree that. So again, it's volume control, and now actually you see that some individual pressed the button and took off that little sign that you could see down here, this circle, this kind of which is a circuit actually, And now it's off, and now you can see the waveform very nicely and square. So it just did that. Alrighty. And now what's the load again?
Elastic.
Elastic mainly, right? So
Yeah.
you see that big
Yeah.
the rise in the pressure. Can you comment on the expiratory limb? Does that look like elastic too?
Yeah, I think so, but there is a negative flow just after that. So I wonder.
Like
So
this
the-
thing, little
Yeah,
thingy?
so that means the patient at that time is breathing out a little bit more. I don't think this is. I don't think this is Autopeek.
But you see this little
Yeah,
thingy.
yeah.
But so you think that this is elastic,
Right.
you know, right?
Yeah.
During inspiration and expiration?
Yeah.
Okay. What about PV discordance? Do you see any patient
No.
activity?
No.
None.
No.
No. So this is not patient activity. That's okay. I just tried to because you said I see a little bit of patient.
I think.
What do you think it is?
Well, the pressure is going up, which means that the patient is blowing out. There's some air that's coming out through the circuit.
Yeah.
You know, I think the only person who can breathe it out is the patient.
Love it. Alrighty, and so I'm gonna put here a question mark, Udi question mark, or unmentioned fellow question mark. So now here we are. There's these little divots that are occurring over here. You can see them here. And you can see them elsewhere. Now, what do you think about the pressure waveform?
So I think the pressure is a kind of hump, which means that I feel that this is more probably kind of a chest wall issue, perhaps. When there any kind of active at the very end and exhalation or kind of chest walls kind of compressing and increasing the pressure, because I think that there's an outward hump slightly.
Yeah, so good point. Oh, so you're seeing a change in compliance,
Right.
right?
There
So
is a change in compliance, yes.
something is causing or what it seems to be a change in compliance.
Yeah.
So you see, the slope is going here like that, then it goes like that, then it goes like that, and then it goes again like that, right?
Right.
And there's all these changes in compliance, which are pretty annoying, right?
Right.
So what do you think is that? PMOS?
Not much. Chest wall or secretion, something like a ball valve thing where it's increasing the pressure. Later, it's almost corresponding to the little. Yeah, I don't know. My best guess is chest wall. I think.
So something is changing the compliance.
Yeah.
You agree with that?
Yeah.
Alrighty. The cause is unclear. So
Right.
now you're sitting in front of the patient saying, what the heck is happening here? I don't understand.
Right.
Rob, has anybody put any comments on the chat?
Ariel said something stressing this greater than one or optical illusion due to work shifting.
Yeah,
But there's no work shifting because there's no evidence of PMOS, right?
right.
I also see that the trigger has changed. I don't know whether that has got to do something. It was flow, now it's pressure.
Yeah. But doesn't I will tell you, it doesn't really matter. Nothing changed. But you do see these little things here, right?
Right.
And actually you may see it elsewhere too. You see a little bit attempt over here. You see how it was not here, and you see those things here. So then I change it even further. Why not? To hell with it, right? So let's improve this a little bit more. So now we drop the rate
Mhm.
and the same total volume, but I gave him enough TI time to be able to see if this was actually the stress index. What was happening here? It was so distressing. And so again, it's volume control. We agree on that. But now you have a little bit better view into those aberrancies, and so now you
False trigger.
well, it's not triggering.
Not trigger. Because you have stuck it out with -2.
Yeah, but it's not triggering. But what is causing this
Cardiac oscillation.
Yes, the doctor. So now you start seeing them how they march out at a certain rhythm. You see them? How they have a rhythm. So those are
Cardiac oscillation.
cardiac oscillations.
How did you uncover that?
By just standing in front of the monitor until you said, why would the compliance be changing on this patient? It didn't make sense.
The compliance changed because the heart was contracting and
It's creating an aberrancy because the heart was creating oscillations on the airway that were causing flow and pressure changes, as you absolutely identified here, would change your waveform, and it looks like if there was a change of compliance. So in a situation like this, your stress index is gone, right? It's an irregular waveform, so you cannot read it based on a stress index, just looking at it like that. Isn't that beautiful?
heart planning to it.
Yeah. Rob?
Couple of comments, for me anyways. I think, I don't know if anybody's ever described this, but it seems to me that when you have a very low compliance, and this guy was like around 10,
Yep.
then the effects of the motion of the heart are going to be amplified versus if you had a big compliant lungs, right? It would absorb the motion of the heart. So it seems to me that you'll see this more often with very stiff lungs, although that's something we could probably test.
Yeah, that's a good.
What do you think about that?
I think mainly about the airway, because I think that this, my thought is that this is mainly coming from the atria hitting the main bronchi. And so the more pressure there is or inflation of that, the more it's going to transmit the. So it's very similar to what you're thinking. If the pressures are recorded high, it will transmit it. Or if the patient has a huge amount of a very large heart on its own.
Yeah, that's different. Yeah, a stiffer lung will transmit vibration much better than a compliant lung. And here's another thing: since you turned off the patient circuit compliance, what does that do to the accuracy of the tidal volume display?
Yeah. So you can actually see that there was you see the changing tidal volume exhaled, how it changed. So I mean, the risk of turning off the compliance on a patient like this is that they will be hypoventilating, right? Because now the lung compliance is so low that some of that volume is going to get lost in the compliance of the circuit, so the patient would hypoventilate under those circumstances.
Plus
So
the displayed inhaled tidal volume is going to be off.
That's right.
There's an error. We just wrote a paper on this. Will be published very shortly.
Very good. So the point here is, I mean, I reactivated the compliance on this patient. This patient had a very interesting physiology per se, but I thought that the waveforms were interesting. And I saw a comment come out that if you have the EKG, you could have a diagnosis. Yeah, absolutely. It has to be on your mind that these oscillations are cardiac, and then you look at the heart rate, and then you can put them and try to mark them out. The other thing that we sometimes do, and it's useful for me, is to do an end expiratory pause and look at the end tidal CO2, and you will see oscillate through time as it's moving CO2 through the sensor, which will tell you that those are cardiac oscillations, and you will see and how they march with your waveforms. So, what other
That's a
comments?
good idea. That's awesome. I never thought of doing that.
Thank you, Tim. Go ahead. I saw a comment from Ariel, Rob.
Is it useful to have the tube compensated, activated, and volume control CMV?
Yeah.
Well, the answer would be yes. The whole purpose of that is to make your volume measurements more accurate.
But you're talking about circuit compensation, right, Rob?
Yeah, Ariel, what do you mean by TC? Do you mean automatic tube compensation? Okay, so that's endotracheal tube, not patient circuit tubing. So first of all, ventilators that offer automatic tube compensation, you will note that it has no effect in volume control on inspiration. It can only affect expiration. So tube compensation or endotracheal tube compensation for resistive load only works in pressure control for inspiration, not in volume control for inspiration. It'll work on some ventilators for expiration always, because expiration is always pressure controlled. Does that make sense to everybody?
Yes, and so the key, and this is a common thing that we hear, circuit compensation is very different than automatic tube compensation. They are two different things, right, Rob?
Correct.
One talks only about the circuit itself, so the compliance of the circuit when it's so the volume that gets lost and not delivered to the patient because of the circuit distending every time the pressure is applied, and that leads to less volume being delivered to the patient. The other one, tube compensation, talks about the ET tube and the pressure difference that occurs because of the size and length of the ET tube. And so it gives pressure to compensate for the pressure loss that occurs trying to make the patient breathe like if it was unassisted.
Yeah, that's the resistive lobe of the endotracheal tube. Resistance times flow.
Exactly. Very good. Good points. Good discussion. Any other comments, Rob?
Nope.
All right, so let's move to the next. This one comes with love, also from the one of our patients. I wonder if there's anybody that wants to give it a try. If not, I'll do it. All right, so we'll get started. So this is CMV, and in this ventilator SCMV, I mean, you can see how challenging it can be just walking by saying what does this mean and what is the mode. So by knowing on this ventilator it's a Hamilton, it essentially this mode is volume control, and I'm going to walk you through it. Volume control CMVS, and there's some clues here, but again, this may generate some challenges when you're reading. You have to remember the Hamilton ventilators have the flow sensor is proximal, okay? And so the proximal meaning there's the ET tube and the two circuits go there, and so it's measuring. And so this waveform, just like the prior one that I showed with circuit compensation, is actually the real flow that is occurring, even though if you would put that sensor in the ventilator, it would look like a perfectly descending ramp, in this case, waveform. So that may throw you off, but you have other features that will help you here. One, you can see that the volume is not changing throughout. Number two is obviously some of the settings here. And number three is if you look at the pressure waveform, you can immediately see that for each one of the flows that are occurring, there's evidence of work shifting, right? And there's different levels of work shifting for this patient. There's, I mean, this patient is pretty active, and every breath the patient takes has using different PMOSes as it should. So what is the main load? When I see this, the main load during inspiration is definitely PMOS. There's a lot of activity. As you can see, instead of looking this waveform, if life was pretty in a descending ramp, it should look essentially like that, like this. Probably a little bit closer to this one over here, which is a little with less PMOS. But that's how it should look. And then during expiration, again, you see actually evidence, instead of decaying nicely as it should, as I'm pointing right here, you see evidence all of this area is area of PMOS. So, and you can see that that is occurring throughout the breath. So this is a patient that is breathing in and out really actively. And actually, you have these little divots that we're going to talk in a second about. So during expiration, there's also a lot of PMOS. So in this patient, just looking at this waveform, I cannot in any of the waveforms come to terms to say he has an elastic or resistive load. The PMOS is hiding everything on this situation. Then you have the PV discordance, and I start by the trigger. And just to remember everybody on this call, every ventilator has a way of marking when the machine thinks that the patient is triggering. In this ventilator, in the Hamilton, it creates this little triangle that you see over here. So all of these little triangles are markers that this is a patient trigger breath, or that the ventilator thinks is a patient trigger breath. There's other markers that we can see here that help us. One of them is you see the pressure dropping below baseline in each one of the breaths before the trigger, which tells me that the patient is generating the trigger action for this patient. And the flow crosses really rapidly in this patient that is doing active exhalation and inhalation really through the baseline. So again, it tells me that this is all the triggers are by the patient, and there doesn't seem to be a major decay on the pressure from the baseline. So I'm going to call this one essentially normal trigger. Now there's a couple here that missed that there's evidence of inspiratory effort after expiration. So these are, to me, this one is a failed trigger, and this may be either an early cycle or another failed trigger. So I'm going to call that there's failed trigger ×1 at least. All right. During inspiration, we talked that this is all work shifting, and what work shifting means is that the ventilator is now doing less effort, less work, and the patient is doing more of the work. And so all of this area right here that should be ventilator work is now patient work. Now, however, you will notice that none of them goes below the baseline. This is pretty close, but it doesn't go below the baseline. So still the patient, even though it's doing work shifting on each one of the breaths, the patient is getting more flow than the patient is asking for. So in this circumstance, there's work shifting, but it doesn't fall into what we call severe. It's pretty important and should probably trigger a change in mode or on sedation or whatnot. But I would put it there as a thought process for you to, I mean, we don't know enough about how much work is good and how much work should the patient be doing. But in general terms, if it's not dropping below the baseline, it means that the patient is getting some support. In terms of cycle, I think that majority of the cycles seem to be normal, although we could argue that these changes on the end inspiratory pressure may be delayed cycle, but I would say that it's probably more than anything normal. And there's one that I'm suspicious that this may be early, which is this one over here that I circled. And then expiration is all expiratory work. So this is a common area where people make errors of thinking that this may be Autopeek because of the way the waveform looks, but we cannot really say that there is Autopeek. There may be some air trapping because the rate is going faster for the patient, but as long as the area under the curve here and the area under the curve here are the same, there's no air trapping. It's just the waveform. This is a common error that we see, that people interpret this as Autopeek, and it's not necessarily Autopeek. It's just a change from active expiration to active inspiration. All right, Rob.
I agree with everything. There was a comment about intrinsic or Autopeek being high, but as you said, it's only defined for passive exhalation. This is clearly active exhalation for every breath that I can see, and so Autopeek is undefined in that situation.
I have a question.
Yeah, go ahead.
So one comment is that it's nice to see the square root sign and the differential being, this is not a leak, but an active exhalation before the inhalation before the exhalation finishes.
Yeah, good catch.
Yeah.
The other thing is that what is when the volume goes negative, what is, I don't know how to interpret that.
Excellent thought process. So and actually this is a good item. So let's start with the first breath. Okay, so this is the first breath. And if we see the patient got this amount of tidal volume, then exhaled, and then after the patient exhaled, the patient started another breath, right? But there's a difference, which is this amount of difference, which you call the square root sign. So that difference could be a leak, or it could be air that stayed inside the patient, right? The next breath gets triggered. The patient gets exactly the same amount of tidal volume because it's volume control, right? Now the patient exhales. What exhales? More, right? So because remember that it resets the volume measurement to 0 whenever you start a breath. So if the patient had more air inside, then it will be able to exhale. Or if the patient coughs, you still can cough more from the residual volume, right? The next one, patient takes a breath in, there's a little bit of air that gets trapped, a little bit, and then the patient exhales. The rest of it. There you go. So that kind of highlights those behaviors, and you can see that in this breath and in this breath, so in A and B, the amount that the patient inhaled and exhaled was exactly the same, even though the waveform may look like there's Autopeek, right? Good observation, Woody.
There's a good take-home message from this, and that is volume control is defined as inspiratory volume preset. Volume control only applies to inspiratory volume. The patient is free to exhale as much or as little volume as he wants, because exhalation is pressure control, not volume control.
Excellent. That's a great message. Love it.
Yep.
All right. Any comments on the chat, Rob?
Nope.
All right. Excellent. All righty. So let's do one more. This one, I really love this one. This generated a lot, has generated a lot of, and this comes from Federico Gordo Vidal in Spain. He tweeted this image, and then Ariel Garnero put it up, and it made me wonder about life and the pursuit of happiness. So, is anybody wants to read this one? All right, let me walk you through these. So the first one is, what is the tag? So I'm gonna venture myself to say that this is volume control CMVs, although the S, I'm gonna tempt Rob to slap me a couple of times, but it generated some anxiety on me. So why do I think this is volume control? Well, I look at the flow waveform and it looks beautiful. It's a square waveform, right? In each one of the breaths that we can see, and I presume this one too. And for the sake of completeness, I presume that this one ends up here like that. I'm just gonna put it so that it doesn't look so horrible. But it could have been higher. I don't, but it's still, you can see the difference. This is, so the flow is being controlled. I have no question about that. So it's volume control. It's CMV because all the breaths that I can see over here are cycled by the ventilator. And so you can see that this is cycled by time, cycled by time, cycled by time, cycled by time. So each one of the breaths is cycled by the setting, which tell us that this is all breaths are mandatory. And I would say set point, because you're supposed to set the volume that the patient will get, the I time and the flow, and the patient will get it. Now, the odd thing here is that we see different flows. And actually, probably the best example here is this one, in which it goes from this amount of flow. And you can see how the next one looks a little bit higher, and the next one a little bit higher. And for a while, I thought that this was like an optical illusion, right? I said, well, maybe it's perspective, right? But if you look at the first one, you see exactly the same. You see the differences in the height of the flow, which didn't make any sense to me. Let's go to what is the load, and we'll come back to this flow targeting scheme. I like that flow targeting scheme. Thank you, Uri. So what is the load? So in the first one, And in this type of ventilator, which Ariel told me, and I think that he is completely right, it's a PB840, 960, sorry. The way to know that it's a patient trigger breath is that it appears in the top, sorry, on the screen, not necessarily on the waveform. So there's no way to see it here, but there's some things that tell us that this is a patient trigger breath. This one seems like a machine trigger breath. This one seems like a patient trigger breath, and you can see that the pressure drops a little bit below. The same with this one over here, and the same with these other two that are extra here. So they seem to be patient effort occurring here. But on the first one, you can see a very high steep rise on the resistive, which tells you that this is a resistive load. So from here to here is resistive, and then this is the elastic load. And actually, you can see that there's a pause, end inspiratory pause, and from that end inspiratory pause, so this difference from here to here would tell you that this is a resistive load. In the second breath, the patient barely had any chance to exhale, and now the resistive load looks probably a little bit smaller, but you can see how the steepness of the pressure waveform changed, and this looks even more steep, which goes with the classic event which we're seeing here, which is this multiple trigger. There's a breath with almost no exhalation or with less exhalation than expected, and another breath in, and so that breath that had been delivered, now the patient is receiving another one on top of that. And because it's receiving another one, now you're seeing a drop in compliance because you're over distending the lung. And the same thing happens over here. You can see the big step on the resistive step. The next one, you can see how the steepness of the compliance part goes up. And in the last breath, in which now you have three breaths on top of each other, the steepness is horrendous. So it starts with resistive on this one, and then it just starts going into an elastic load of hell, in which you have distended that lung to a humongous size. If I see the expiratory part, you can see this in this initial breath, but I think that there was an effort, and that's why it triggered. The same happened here. But in the second one, you can see how long it takes to get to baseline, which makes me think that it's again related to a resistive load. So I would say that the main driver is resistive, but then when you over distend this patient, it goes to an elastic main load. In terms of the trigger, I would say it looks normal. I was trying to find if this was a false trigger that was generating this, but I don't see that. It looks it's not fast enough to generate this. So I suppose something is happening with this patient, and he gets the breath and then does an inspiratory, probably in a reverse, even an early trigger occurring here. I'm not entirely sure. I'm having some challenges with it, so I want to hear the rest of the team with it. The inspiration, I didn't see any work shifting, any clear work shifting, unless there's something under this one. And actually, maybe I'm right here, and this is a early trigger, and then it triggers another one. This is a major inspiratory effort, but doesn't really make sense. Something is triggering these breaths one after the other. So I don't see any work shifting or any major work shifting. I'm gonna call it normal. The cycle seems to be normal, or actually probably early, if we call this that there was still effort, but you can see how the peak flow continues to increase instead of decreasing. So I'm still having challenges with this one. I'm gonna put early, I'm gonna put my money there and then have the rest of the Twitter bursts execute me. And then expiration, it seems to be passive or normal. So that's what I can say about this. Really challenging curve. Go ahead, Udi.
I think the answer probably lies that what is making, it's not time or pressure or flow, what is triggering the vent? It's
Yes.
not the patient. and then what is the vent trying to target? Because it's
Yeah.
not, it seems maybe some form of minute ventilation, because you see that with every breath on the right hand part of the screen, that okay, the vent is saying, okay, you've got a breath. No, that's not enough. I'll give you one more breath. And that's not enough. I'll give you one bigger breath. So what are you exactly trying to target?
Yeah, so 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 there's two questions in this. One is what's triggering,
Yeah.
and the second one is why is this flow changing, right?
What's the target? Yeah, what's
Yeah.
the key?
So Rob, any comments here, and then I'll show one slide.
Yeah, first of all, when we say set point targeting for volume control, simple set point targeting for volume control, we are saying that you set a flow or an inspiratory time and a tidal volume, which ends up being setting flow and tidal volume. And we say that the ventilator doesn't do anything automatically. And from a macro point of view, that's true. But from a micro point of view, the ventilator, very sophisticated ventilators anyways, they look at the tidal volume that's exhaled every breath, and they make micro adjustments to the flow, the peak flow, so that you get the tidal volume that you have set. So behind the scenes, it's always some form of adaptive targeting for these very sophisticated ventilators. And I think that's why you see these small changes in the peak flow, even though the flow was preset and so was the tidal volume. There's a paper written on that by Sanborn. If I could figure out how to attach a document in WebEx, I would do it, but I don't see how to do that.
Yeah, there is actually, I went into, this is something, this is from the manual from this ventilator. And what they do, which I think is happening here, is what we see there, is that they have this compliance compensation that is essentially a circuit compensation.
Yep.
They have it in volume control, and this graph actually you can see is a square flow. Actually, let me change the color of the pen so you can see what I'm highlighting there. So it's in a square flow pattern. So here's the beginning of the flow 0, and then it goes to the peak flow, and this would be the actual goal, right? That's what you said. And then it will calculate based on the compliance an extra amount of flow that it needs to use to deliver that breath. So it's a compensation for volume, what they call volume-based breath. So for volume control breaths that this ventilator has, changing the algorithm. So what I think that happens is what you see over here is that it requires this amount of volume. It calculates a certain compliance, and it says the next one is going to need a little bit more, and then the next one a little bit more because the compliance went up. And then what happened is probably the prior breath over here was one of these breaths, and so it got the same amount of flow, thinking because it doesn't do it in intra breath. I think it does it after the next breath. It gives you the same to maintain that, and because there's varying, oscillating amounts of compliance changes because the patient is air trapping, it's creating these different levels of flow compensation being delivered. Rob?
I don't think it's compliance. As you can see, the peak pressure is increasing for those 3 breaths.
Yeah.
So the higher pressure in the circuit is more volume lost in compression in the circuit. And that's why the next time it gives a breath, it puts out more flow. So the higher the pressure, the more gas loss, the higher the flow's got to be to get the target pressure. I mean, the target volume. And that's what it's doing.
Perfect.
It's just, most ventilators probably don't compensate that quickly. That's why you're seeing these micro adjustments in flow.
Yeah, which I mean, they are not that micro if you see this scale.
Yeah. Yeah.
But they are compensations, not regardless of the event. The question is, does this create any? I mean, what is the effect of this on this patient? Because now you can imagine on this patient, it's adding extra flow to essentially deliver. If he didn't have this compensation in this patient, probably would be a good thing that he didn't get the extra tidal volume that he was losing in the circuit.
What of that trigger?
Yeah. The second question,
Ariel made a comment that what if the IE ratio was preset instead of the inspiratory time?
the I-to-E ratio was preset instead of the inspiratory time.
So I think in the configuration of the ventilator, you can cause it to have a preset inspiratory time. No, I don't think that applies here because in volume control on the PB machines, you set flow and you set tidal volume, and that sets the inspiratory time. Now, the choice between a display of IE ratio or of inspiratory time is configurable, but you can't set it. You can't make this ventilator have a set IE ratio. It doesn't work that way.
And actually, that's a good point. And in these, I mean, I just caught a piece, but they do comment that they don't change the I-to-E ratio when they do this compensation.
Yeah.
All right.
I think that whole effect is just tube compensation or patient circuit compensation, not endotracheal tube compensation.
I wanted to ask the team, do you think that what do you think is the trigger? Is this a PMOS trigger? Is this something else triggering the ventilator? It has to be a PMOS, I think, but I'm not. This one is so odd looking. I mean, there's
some failed triggers. Did you point that out?
This one's over here. I didn't know if it was cardiac oscillations, but it could be failed triggers. You're right.
Yeah, that's a good point. Yeah.
No.
So, second. Oh, yeah.
You don't see them anyplace else on the flow waveform.
No.
If that's a failed trigger, then I don't know whether it gives resistive load.
No, failed trigger is classical for assisted load. But
No, but that's okay. Okay, yeah.
Or just backing up the breath with the long exhale time. Down and try to breathe. Breath, which is
But it's not slow. That's a failed trigger. That's probably a pressure trigger. Why would there be a failed trigger with it as the pressure waveform is absolutely fine?
But sometimes remember that you may not see the changes. It all depends on the scale. So something I don't know what triggered these three breaths. I wish Federico was online so that he could help us to hear more about this patient. But yeah, really challenging waveform. All right. Let's so this is the end of we're to the end of the hour. Really good discussions. That's the CME for those that want to get CMEs, respiratory therapists or physicians. Just scan that and you will get it. For those of you with us, here's the SEVA webpage as well as the CME, and here's our Twitter handles to send us any pictures that you want. You can see that we analyze whatever comes our way, even if it's painful. And my email if you have any complaints about the world. All right. Thank you very much. Have a great day. Thank you, Rob.
Thank you. Bye-bye.
Bye-bye.
Thank you.